I'm Ben Ryman, and this is Behavior Speak.
And it's reasonable and rational, not when you look at the behavior itself, because the behavior itself may look completely irrational.
Hmm.
I've worked with several kids with um, auditory or visual hallucinations, or a behavior that really on the outset looks extremely irrational. There's no
Hmm.
reason why they should be engaging in this, or maybe people go and put it inside the head and say like, oh, it's just a mechanism inside that's making that happen. But when you really zoom out and you take this lens that this behavior is reasonable and rational and serving a purpose for this person, the behavior itself, again, maybe doesn't make sense. But when you look at their set of alternatives and what is actually available to them to solve a problem that's at hand, they may not have any other alternatives to solve that problem. And that's why that behavior is reasonable and rational, because it's the only way that they have to access that critical consequence that they're after. Pathological approach is what like Golddiamond describes in his in the seminal paper in '74, where, and it's the model that we still use today, that the goal of treatment is to decrease problem behavior and to get rid of it, eliminate it, or at most decrease distress that the person is having based on the behavioral profile that they're having. And then the flip side of that would be what's the opposite of pathological would be constructional. I mean, the constructional approach, our focus is never to treat directly the problem behavior at hand, but the question then would be, what repertoire is the absence of that problem? And then we're working on constructing that repertoire. And what we see when we construct that repertoire is that that behavior goes away as a secondary result without ever directly treating or targeting that behavior. And I think that's the kind of the crux of the constructional approach.
Welcome back to Behavior Speak. Today we're continuing our series on the constructional approach with someone who is helping redefine what compassionate behavior analytic healthcare can look like. My guest is Katie Gibson, a behavior analyst at the Vanderbilt University Medical Center, whose work spans severe behavior, OCD, psychosis, medical trauma, and constructional exposure therapy. Rather than asking how to eliminate problem behavior, Katie asks a very different question. What behavior is missing? That simple shift has led to remarkable outcomes, from helping children safely participate in blood draws without restraint to supporting individuals experiencing psychosis by building meaningful social repertoires instead of simply targeting symptoms. This conversation is packed with practical clinical examples and challenges many assumptions about how behavior change happens. Whether you work in healthcare, education, behavior analysis, or simply care about more compassionate support, I think you're going to find this episode incredibly thought-provoking. Here's my conversation with Katie Gibson. Katie, thanks for coming on Behavior Speak.
Yeah, no problem.
So, we could start a bit by just telling us a bit about how you kind of first got into the field. And you told this story before, and I think this might be a cool place to start. You were doing what many of us called sort of so-called traditional ABA with kids with FAS. Tell me a little bit about how you got into that, and then when you kind of realized the change needed to be made.
Yeah, absolutely. I think I started in our field, like most people, as like an RBT, and then went back to school, did my supervision. I was really lucky to have really, really good supervision throughout my coursework. And then when I became a BCBA, I think that my clinical director just threw me straight into the deep end. My first caseload was a caseload of 4 kids with fetal alcohol syndrome, which was quite the lift in thinking about working with these kids. Like, they were having extreme problem behavior. Typical like behavior interventions weren't necessarily like just being super effective. I was having a really hard time, and really thinking about like the linear contingency of like the antecedent behavior and consequence was like just like wasn't doing it. It wasn't cutting it. It wasn't enough. And so that prompted me to go back to school, because I thought, well, maybe I'm just stupid and I need to learn a little bit more. And so I started my doctorate program at the Chicago School, and there, on the very first like month or so of my dissertation journey, I met Dr. TV Joe Lang, who did a keynote speaker event at one of our like residency
Hmm.
programs there. And in that speech, I had no idea what he was saying, but what he was saying did make some sense, enough for me to buy his book online, and it was a pre-order at that time. So I pre-ordered the nonlinear contingency analysis book, and when I got that in the mail several months later and read through it, all the things that he was saying, like, it really started to make sense. And from there, just started applying that to my work and saw a huge difference. And what ended up happening again, like, be able to expand that contingency analysis there, and went just like such a far way. I ended up moving to Columbus to work at a complex behavior program because I really loved that work. And I wanted to move out of the early intervention setting. So started working with kids with really complex disorders or treatment resistant conditions like OCD, severe aggression, self-injury, in a more contained program that is really specifically targeting that complex behavior profile. And then got the opportunity to move down here to Nashville to start a program here at Vanderbilt Children's Hospital, and been working here for the last 2 years, building a program and increasing hopefully some access to behavioral living services down here.
Wow, amazing. Kind of going back to the working with the kids with FAS, what were you seeing in the kids what was going on there that was sort of problematic? Do you have a certification with the International Behavior Analysis Organization, the Qualified Applied Behavior Analysis Credentialing Board, the Behavior Analyst Certification Board, or are certified through your region's Behavior Analyst Credentialing Board? You can earn continuing education units for this episode by going to www.behaviorspeak.com and clicking on CEUs. The first secret word is toolbox.
I think in that population, particularly, just like the response to different procedures, like implementing like immediate consequences and things like that, like weren't necessarily working because what was maintaining behavior wasn't that direct contingency. It was the alternatives that weren't getting reinforced or the alternative behaviors, and they didn't have the repertoires to engage in. And that was actually what was maintaining behavior in these scenarios, not necessarily that direct contingency that we're taught to treat. And so that was the piece that I think was a lot different. And honestly, through not even just kids with fetal alcohol, kids with all kinds of really complex behavior problems that maybe are a little more like resistant to our typical treatments of just like manipulating the antecedent or manipulating the consequence. Those behaviors are almost always maintained by contingencies that are happening on alternative behaviors that are not directly observable. And so we were able to treat those. That's what made the biggest shift towards the secondary, decrease of problem behavior.
Hmm. And was it just sort of, this isn't working, so I'm going to go get a doctorate? How'd you kind of go from like this is tough work, I need a doctorate?
I just wanted to learn more, and thought that maybe learning some more would help. It did. Meeting Dr. Lang really helped expand my view and how I was treating and interviewing some of these like more complex contingencies. I don't think you need a doctorate to do this work, but that was just my kind of like entryway into the nonlinear area.
Yeah, right on. And for people that are maybe new to this is I think the fourth or fifth episode in this series, but how would you describe the constructional approach in a way that makes sense to someone steeped in these kind of more compliance-based models?
Yeah, I think that's a great question. And I think like at its roots or at the base, the constructional approach is just the idea that there's kind of like two ways to like, go about treating behavior. A pathological approach is what like Golddiamond describes in the seminal paper in '74, where and it's the model that we still use today. The goal of treatment is to decrease problem behavior and to get rid of it, eliminate it, or at most decrease the stress that the person is having based on the behavioral profile that they're having. And then the flip side of that would be what's the opposite of pathological would be constructional. I mean, the constructional approach, our focus is never to treat directly the problem behavior at hand, but the question then would be what repertoire is the absence of that problem, and then we're working on constructing that repertoire. And what we see when we construct that repertoire is that behavior goes away as a secondary result without ever directly treating or targeting that behavior. And I think that's the kind of the crux of the constructional approach. And then there's like a couple like pillars or things that typically when I talk about the constructional approach really falls back on. And the way Goldman really hit on too is that like all behavior is reasonable and rational. And it's reasonable and rational not when you look at the behavior itself, because the behavior itself may look completely irrational. I've worked with several kids with auditory or visual hallucinations or a behavior that really on the outset looks extremely irrational. There's no reason why they should be engaging in this, or maybe people go and put it inside the head and say like, oh, it's just a mechanism inside that's making that happen. But when you really zoom out and you take this lens that this behavior is reasonable and rational and serving a purpose for this person, The behavior itself, again, maybe doesn't make sense, but when you look at their set of alternatives and what is actually available to them to solve a problem that's at hand, they may not have any other alternatives to solve that problem. And that's why that behavior is reasonable and rational, because it's the only way that they have to access that critical consequence that they're after. And if they had these alternative behaviors within their repertoire, which they clearly don't, or the reinforcement's not equal or better in some way, 'cause we're inherently lazy human beings, and if we had a better way to solve our problem, we would choose that 100% of the time because we're not going to exert energy that's not necessary, that's biologically and evolutionary, not within our repertoire or scope. We're not gonna put effort in where it's not needed. And so I always kind of like talking when I'm talking to like nurses or psychiatry or different groups of people. We're talking about like if you think about a toolbox, you reach down your toolbox at the bottom of every single person's toolbox is severe problem behavior. The reason that maybe you and I aren't flipping tables or punching each other in the face, besides being virtual, is that when we reach down into our toolbox, we have a ton of other tools to solve a problem that's at hand. But if we are backed into a corner where we didn't have enough tools or we used our tools and they didn't work, when we reach into our toolbox, everyone is capable of reaching into and grabbing severe problem behavior to solve a problem.
Yeah, I love that. We're gonna talk a lot about your work in the hospital and exposure therapy and all that sort of thing, but I wanted to touch on something you said, and I'm hoping to have some other folks on to dig into this area a little more too. These cases where you have sort of these behaviors like you said, like the auditory hallucinations, the delusional behavior, these sorts of things, the voices and so on. It seems like throwing a chair across the room would be a more likely tool to grab from the toolbox. I'm curious about sort of maybe some of the conversations maybe you've had at Joe's lab. I know and Paul have had a lot of history working with cases like this, but this area is kind of so new to me, and trying to sort of grapple with the verbal behavior bit of it all, but then also the, I guess, psychiatric, mentalistic, whatever term you want to use, a bit of it all. I wonder if you could tell me a little bit about what do you think is kind of happening in these cases? Are we suggesting that these folks aren't having these experiences and that these are simply tools of verbal behavior they're using to meet some end, or is it a little bit of a both? Do the interventions that are successful for you folks in these situations, I mean, obviously you don't know because you can't see inside people's sort of minds, but are we suggesting that they're all just tools they're using and not actually something that's happening? It's hard, what I'm getting into, these kind of weird kind of sort of, sort of metaphysical, almost spiritual type questions, I suppose.
Yeah. One of the psychiatrists that I work with currently, I really love her work. She does really good work with our patients. And I like the way that she talks about like we all are kind of like, and literature kind of really like leads to this too. Is like we're all kind of like genetically preloaded for different things. And so you may have like a psychosis seed that can be watered with, excessive use of marijuana or excessive interactions with like really traumatic events or things like that. It can help grow these like kind of like predispositions,
Hmm.
and that's all behavioral contingencies too. So we may already be kind of like genetically or like destined like loaded for these different disorders, and
Hmm.
the contingencies can shape or dissuade the emergence of those. And for like psychosis, for example, I'll give you an example of a kid that we treated with psychosis who came in. He was, he had all these delusions and about him being Jesus, and that he had a lot of like religious scrupulosity around being Jesus and interacting with other people. And he wanted to make it like an AI, like home robot. Was having a lot of like grandiosity. And I think it's very easy to like look at a case like that and then pathologize like, oh, these are delusions,
Yeah.
hallucinations, like this is like, a first break psychosis, or this is going to lead likely to schizophrenia or whatever that looks like. I sat down with him because he also had autism. When I first started at the hospital, they said anyone with autism, we're just going to call Katie. And so I walked in, and I also had the same thought, like, oh, this seems like very pathological.
Right.
So I'll do a constructional interview anyway and just kind of like see if there's anything possibly that's going on underneath of this. When we started doing the construction interview and asking him questions, I was like, like Jesus is a really nice guy. Like if you are Jesus, what would you be doing? Like, what would you be doing to like help yourself out, or how would you be helping others? Because that's what Jesus did when he was around. And the kids started saying, "Oh, well, yeah, absolutely. I'm Jesus, and when and Jesus is a good guy, and I would be helping other people make friends. I would be helping people who didn't have friends make them, and I would have all of these things to help people get together and have a good time." I was like, "Well, that's really interesting to me. Like, do you have a good time? Do you have a lot of friends? Like, what does
Hmm.
that look like for you?" And so the more and more we uncovered, the more and more we learned that like he actually didn't have any friends, and in fact, he had a really traumatic experience where peers at his school had called the police saying that he had a weapon to hurt people at the school, and police had come and raided his home, which was the only place he ever felt safe, or like he could interact with people like online and things. They had taken his computer, and so the only like positive social interactions he had been wiped away. Again, maybe he had like this preloading for some psychosis or things like that. But and then the AI home robot, you said, well, what would your robot do if you got to create it? If you got to create it, it'd do everything that you wanted it to do because you had wrote the code. And he said, well, it would be a bug in my ear that would tell me how to make friends. And so very clearly, we also learned that very quickly, he didn't actually have the social skills also to make the friends that he wanted. And I was like, well, what do you want from this experience? Like, what do you want from being in the hospital? And he said, oh, well, I heard that I could go over to the psychiatric hospital and I would get to have a roommate. He really wanted to go to MIT. And so MIT, he would get a roommate that had similar interests to him. He said, well, at the psychiatric hospital, I'd get a roommate. We'd have similar interests because we're both interested in mental health. I was like, well, that's maybe not the most positive thing to be talking about. And so he was recreating what he really desired with
Hmm.
the only skills or access point that he
Yeah.
had. We were able to deter him from going to the inpatient psychiatric unit and put him in our partial hospitalization program. And I worked with his provider to help him build social skills for him so that he could access peer relationships outside in the community. And when they started building up social skills and teaching him how to interact with kids his age, his family also moved him schools to where he would have like a clean slate for increased social interactions with the new
Hmm.
skills that he had just learned. And as he
Wow.
started to learn these skills, the psychosis symptoms went away. And he had his first sleepover. He has a small group of friends that he likes. He was able to get back online and engage in like he was so smart that like kids at his school just weren't as smart as him, honestly. And so he was able to interact online with kids who did have like the same interest or like the level of intelligence for like the AI and type stuff that he was interested in. And so like as he started building these relationships, the psychotic symptoms went away because they weren't necessary anymore. And so maybe he was preloaded for some of these symptoms to occur, but they were still functional to get him what he was after.
The second secret word is freedom.
Hmm.
What an amazing case. And it really does stem back to sort of this pathological versus constructional thinking. You're not saying, this is real, this isn't real. It's potentially something that maybe exists and grows into this adaptive tool for individuals to meet needs. Interesting how I think that's the first time. Again, this sort of series of podcasts is my introduction to the constructional approach. It's half the reason I'm doing it. And so this is the first time I've heard about the constructional interview sort of being used in a way to sort of, well, one piece I really like is that you go right in there, not disagreeing, not combating the Jesus idea or any of those pieces or the AI robot or whatever, and instead just really take those really preferences that he has at this very moment, that he's Jesus and he's going to have a robot, and embed those into the constructional interview to really get some valuable information on what he's actually seeking and what the true function is here. And really, yeah, it came down to sort of these missing pieces. And so in the end, it's possible that maybe if he is sort of predisposed, and again, not our realm, but if he is sort of predisposed to psychosis or whatever, I really like that sort of thinking, it's possible maybe down the road there'll be some other skill he's lacking and he may come back to
Mhm.
that as a tool. And again,
Yeah.
we can kind of
And if that
address
behavior
it that
did
way.
come back, that would be like a red flag to his family or the system that maybe there is a
Hmm.
skill that's lacking. And we do that work with families too, of like teaching them to also become contingency analysts. of like when you see these behaviors return, it doesn't mean that everything is over or backsliding. It's a
Hmm.
red flag or a check engine light that something else is going on, and we need to do a little bit more analysis and figure out what that is, and then order to build the skills around that area. Because once you've engaged in behavior, you don't ever unlearn behavior, and that behavior is always like sitting at the bottom of your toolbox or
Yeah.
within your repertoire, and it can always reemerge.
And sort of one other angle is I'm wondering about is, so it sounds like what's it like? What has been your experience? Sounds like you've had some good experiences. Maybe maybe the only ones you really had are in the context of the hospital, where you have already have these relationships with staff. But what has it been like, and or what's your experience been like? What have others been like collaborating with psychiatrists and mental health professionals who believe more this is a medication type situation that really no, it's psychosis, it's delusions, they need
Hmm.
meds, and what have those conversations been like?
Yeah, I mean, working with any other like profession like comes with its own like things. We see this like when people who are interacting in schools or other places. I think probably schools is probably the most closely related, but there's always like differences of opinion. I always just take a contingency analytic approach there too of like,
Hmm.
what's the function of their behavior? What is
Hmm.
the only tools that maybe they have in their toolbox?
Hmm.
Not saying that we're always right or they're always right or things like that, but never kind of like go into like a collaborative thing, like disagreeing, because we're
Right.
all there to help this kid like decrease the amount of distress that
Yeah.
they're having. But I think like personally, like I walk into there, and if I'm working with a psychiatrist, I worked with a psychiatrist on that case. She watched the whole constructional interview. We walked out and she said, "Oh, the only thing I actually really want to prescribe anymore is a friend."
Hmm.
Which I thought was really cute. But the medication can help to bring us to a place where we can actually build skills. Sometimes we're seeing kids who have such an increased level of agitation, or they've gone through so many like extinction bursts where they've had so much extinction induced variability, where we have so many things going on, or we do need a little bit of medication to help us come down to even see the problem at hand, or even be able to interview them, or even be able to do some behavior analytic
Sure.
tools. And so there's nothing wrong with medication or anything like that. In a lot of the cases that I've worked, we've been able to reduce psychotropic medication significantly over time as the kid learns the skills. But whenever I'm talking with families, I always talk about like medication and these kind of like pathological approaches can be like a bridge to get us to a place where we're able to learn and we're able to build the skills. So if we're engaging in all of these like extremely severe behaviors, we may not even be able to get to this point where we're able to build skills. And so I think everyone can add value to a case. I'm a big believer, obviously, in behavior analysis, and I think that we have a lot to add. But there's other areas that can also help us get to where we need to be able to build skills, and that can be a bridge or a band aid to get us there.
I love that the psychiatrist said we need to prescribe a friend instead of a medication. I love that she was able to sort of pick up on that piece. Really cool. Okay, I want to get into the main lens of the conversation around the constructional exposure therapy and particularly in kind of hospital settings. When you first tell me a little bit about what it was like when you first kind of encountered CET and how it felt maybe different from other models of desensitization or extinction and whatnot.
Yeah, my first case I used CET was actually a case with a girl who had really severe OCD, and she had really severe contamination OCD. And so, like, her family had walked into the house for the first time. They only had a couch, a TV, two beds, a kitchen table with one chair. Everything else, her contamination OCD had eliminated from the home. They couldn't have any trash cans or garbage cans, no toilet papers in the bathroom. They didn't have anything in the home at all. And so I walked into that case, knew that there were some things that we would have to bring into the home. And in the constructional approach, so we did a constructional interview with the family. And I think there's a differentiation between the CET as a component of a grander constructional approach, and a nonlinear analysis gets us to the areas where we need to build skills. CET is what I would put under a topical intervention. And so these are like the behaviors we can see. This is a way to address behaviors that we can see underneath the iceberg. Are these systemic interventions where we're building the skills in which the absence is the problem? And CET has that inside of it as well, but really is on that more topical intervention component. And so for this girl, we need needed to engage in some topical intervention so that we could even get underneath to start working on some systemic interventions in order to build the skills that she needed in order for this OCD to secondarily reduce. And so we started off, they weren't, she wouldn't let their trash can be on the property. And so the trash can was maybe about a football field away off the family's property. And so we asked there, like, what behavior would be the absence of this problem, like of the trash can? This is a very like insular issue within a big grander scheme of symptomology that we were looking at. And so the trash can, zooming in, what behavior is the absence of the problem? We said, well, the trash can's outside. What would she or should she be doing outside on a normal day if the trash can problem wasn't an issue? And her mom was like, well, she loves to swing. She loves to bounce the ball back and forth. And so we had our staff work to throw the ball back and forth with her. And while we were doing that, I started walking. I got my steps in this day, but I was walking the trash can back and forth. And I think the thing to really like drive home when we're talking about the constructional approach and CET is that it wasn't about the trash can. It was about the repertoire that was missing or needed to be reinstated in that
Mm,
instance. That moving the trash can and the negative reinforcement of removing the trash can was a means to the end to build the behavior or reinstate back the behavior that was missing or had dropped out. And so it was really about building back the behavior of the leisure skills, the outside leisure skills, swinging, bouncing the ball. She had
mm,
this like scooter that she would like ride into a circle. There was like a little indent in the concrete from where she would ride the scooter around
wow.
over and over and over. She hadn't done that in years. And so bringing back these behaviors, turning these behaviors back on under the context of that salient negative reinforcer of the trash can. So it's not about the trash can. It's not about the adversive. It's not about that. We're using that salient stimulus to negatively reinforce building back the repertoire. And that's the same in the medical setting too. We do a lot of work with needle desensitization for vaccines and blood draws. Whenever I'm working with nurses and medical assistants, this is the point that we really drive home to is it's not about the needle. It's not about the pain. The removal of the needle is building the skills for the kid to participate in their treatment. It's a means to an end. So it's not about the needle itself or the distance, increasing or decreasing the distance. It's about how can I use this distance contingently to build the skills that's actually necessary for this kid to participate in this blood draw, for this kid to participate in engaging in their outside leisure skills or whatever that is, if that makes sense.
Yeah, I mean, so going back to the trash can, and so initially, was it just a matter of removing the trash can altogether and then just getting the girl to start going on the swings again and playing on the scooter with no sort of fear stimulus available? And that's kind of, and then you were just slowly introducing the stimulus as you went along. Is that kind of what it looked like, or?
Yes and no. I think
Mm,
the distinction would be the first we had her walk outside where the trash can wasn't, and she went back inside.
mm,
Then we walked outside and we handed her a ball. I moved the trash. The trash can was now within sight. I moved the trash can away, and what we captured there was her holding onto the ball. Right now, we're building the skill of her starting to engage
I
in a,
see.
a previous leisure skill. Then we walk outside, pull the trash can within sight, have her throw the ball. Now, removing the trash can. The removal of the trash can reinforces and captures her throwing the ball back to the staff or the RB team. So then we go inside, take a break, come out, trash can's within sight. Now she's throwing the ball back and forth. We do that a couple times. I remove the trash can. We go back inside and take the break. We're reinstating leisure skill with the
I
removal of the
see.
trash can
I see. So,
until
yeah,
we were able to move the trash can all the way to where it was supposed to go.
right.
Now she's just swinging. And now she's throwing the ball back and forth. She's riding her scooter around and around and around.
I
But
see.
those were instated and captured with
Got
the
it.
negative
Yeah, yeah.
reinforcement of the trash
So you
can.
kind of had a couple things happening. You had
Hmm.
the sort of desensitization or whatever to the trash can at the same time, and you were using, and this is sort of this shaping by negative reinforcement idea that you were using
Hmm.
the removal of the fear stimulus to shape the the play skills back to kind of where they were.
Hmm.
I love that. And so I think that the takeaway is it's not just, girls standing outside and being slowly introduced to a garbage can.
Hmm.
There's intentional sort of skill building kind of happening at the same time.
Yeah, and that's the difference between like traditional exposure treatment and CET is that we're really focused in CET on building that repertoire in which the absence is the problem. And so at the end, we had like a switchover effect where we had her open a new thing of bubbles and we're blowing that while she created trash. What do you need to do with trash? You need to throw it away. And so then she took the piece of trash, went over and threw it away. Now the garbage can is also becomes valuable. We've switched over. It's more of a positive reinforcement scenario. We're moving from negative reinforcement to positive reinforcement at the end. We're having the switchover effect. The trash can's actually valuable to her for the activities that she's engaged in that we turn back on with the negative reinforcement.
And tell me a little bit more about, I think it's interesting that you kind of frame the CET as a sort of topical intervention, and then there's all these sort of underlying pieces. Can you tell me a little bit more about what that might look like, what kind of building the systems look like, and so on, and in conjunction with CET?
Yeah, yeah, absolutely. Like CET again, like was kind of like a means to get us to a place where we were able to like reintroduce stimuli back into the home. And so we knew we needed that because when we looked at her grander like picture of how OCD had become problematic or very difficult for her and her family, what we saw is that she had several like changes in her life that kind of led her to like systematically like her dad got a new job, she changed schools, like
Mm,
not like one event, but there was a series of like small events that really changed the salience of how often she was getting reinforcement from her family, and changed the variability of that schedule of reinforcement. And so what we needed to do, and so when she engaged in OCD patterns or severe aggression associated with her OCD, people in. And so her mom would sit with her on the couch almost 24 hours a day. And when her dad would come home, she would rip his clothes off of him so that he would go to bed and then he would put clothes back on. That would mean he was leaving the house. And so she was trying to manipulate, kind of change the environment to where parents would be with her all the time within her like kind of like realm of control. And so we knew we needed to build up her skills, which she actually already had it within her repertoire. And she had a lot of prerequisite skills. She had a ton of really great skills coming into things. We also learned that from the construction interview and that assets question. That's kind of section in the construction interview. So we knew she had a ton of great skills. We knew she had most of these skills already within her repertoire. We just needed to turn them back on, work on that schedule. Of reinforcement of parents and make that less variable. And so we built back the skills in which the absence was a problem. She had had previous success. We're reinstating that success and changing those variables, the variability of her parent interaction and building up her ability to expand her social interaction to peers at school. She had a really bad, she was really hard to understand with her articulation. And so she was supposed to be wearing hearing aids to help her articulation so she could have like self feedback. We used CET to help get her to wear hearing aids. When she started wearing hearing aids, her voice became more clear. She was able to contact more peer interactions because now peers could understand her.
wow.
And so building up some of these skills was the absence of which was the OCD problem. And those OCD symptoms, that severe aggression, dropped out without ever targeting that. We only reinstated and built up additional social skills and leisure skills and engaging with our parents like across household activities. So mom and dad would go like, you have to cook, you have to clean, you have to do these things in order to live. And so they would when they would remove that attention, then the OCD behaviors would really like inflame and crop back up. And so we had her go with them to start learning how to cook or learning how to like grab things out of the pantry or do different activities around the house with her parents, not without them. And so when she was with them, the OCD didn't have to uh, inflame or become more severe or lead to severe problem behavior because she had another way to access mom and dad in a much better way.
Really cool. Okay.
And so CET there can be a kind of like a bridge to get to some of this
Yeah. Yeah.
systematic.
I see that. Yeah. Awesome. All right, let's get into some of the hospital work. When we think about kids with severe problem behavior in kind of medical settings, I think the system often defaults to restraint, sedation, sort of some sort of way to get it done quickly. What were you walking into at Vanderbilt and nationwide?
Yeah. I think what you said, like restraint is just widely used in a medical setting. And the constructional question would be like, why? Why is this reasonable and rational behavior? Here at Vanderbilt, we did a pilot. We do a lot of one of the psychologists and I teach a neurodiversity affirming care class across our kind of like hospital enterprise. We've taught it over like ish times now, which is great. Building some skills and like repertoires for our medical staff to engage with our neurodiverse patients in a much better way, in a more understanding way. And from those classes, we always get nurses, or medical assistants, or physicians who want to be a champion in their area or their unit. And a lot of times they'll come and say like, "Hey, like actually, we really struggle with neurodivergent patients in our setting, in our unit, in our whatever it is." And so we get that quite a bit. And we've sat down with several unit leaders and champions to say like, why do nurses feel compelled to engage in procedural restraint or to engage in holding a kid down? Same thing said different way. Uh, and so and procedural restraint is used across the country in every children's hospital and every doctor's office. Sometimes people are saying that that's a comfort hold, which I think is maybe a nice way to say like you're being still engaging in procedural restraint. Um, I don't know who's more comfortable in that scenario, or they're holding kids down, or they're engaging in physical restraint with multiple nurses in a room holding a kid to get the procedure completed. And this happens across the board. And so my question was, like, why do we feel compelled to do this when we know there's tools in literature, not even CET, but there's all kinds of literature that says that can help in this area, decrease procedural restraint. Like, why do we still feel compelled to engage in procedural restraint? And what we found in the setting where we did our first initial pilot program was the nurses would walk into a room, and maybe this kid had had 3 or 4 previous workplace violence events where they had seriously harmed a staff member, and that staff had no idea. They came, now they're the 5th staff who got punched in the face. And so just by, we made a tiered model. So our very first tier is really just collecting behavioral history for patients. They fill out a quick 4-question survey, and their families are like, have they ever had, how do they respond to needle-based procedures in the past? Good, bad, ugly, whatever it says on there. And then what accommodations do they need to help it go better? If it has gone better in the past, what does that look like? And then what can we do for you today to help this go as smoothly as possible? And never ever has a family said it goes best when 6 nurses dogpile on him and get the procedure done. We've never seen that in any of our surveys. Our second section was looking at accommodations and modifications to care. And so of these times that have gone well in the past where this kid has gotten a really successful procedure, what accommodations and modifications have we used? And for almost 80%, 85% of kids we see come in, if we just give a little bit of modification or accommodation to care, like they can get a safe blood draw with no problem, which is great. That's what we want to do. And then there's a subsection of like 20, 25-ish% of kids who do have like pretty severe needle phobia. And they're going to be a hard stick no matter what accommodations and modifications you use. It doesn't mean that we're not using accommodations and modifications, but we're using accommodations and modifications to help decrease distress. And then we're going to use CET on top of that in order to rapidly expose a kid to the procedure and build the skills necessary in order to engage in that treatment. And one of the most fascinating pieces from our pilot that we found is that and this has been true when I'm using CET in the inpatient hospital side as well. When we do CET with a patient for the first time, we're building those initial skills to participate in treatment. Every subsequent CET session after that takes less time. And so the first CET session may take 15 to 20 minutes to get a safe blood draw. The next time that patient comes in, they may not even need CET, or they may need CET just for a couple of steps in order to reestablish that skill that was previously taught, and it takes less time and takes less time. Or if we have a patient, I work a lot in our hematology oncology unit with kids with cancer. They have to get all kinds of medical treatment, and it's like the frequency of it is insane. And so we have kids who need like their vital signs taken, which sucks. Like no one wants their temperature taken, their blood pressure taken. Getting your blood pressure is like a sensory nightmare. And your pulse ox read. Some of the kids have to do that every 15 minutes throughout a day, which is 4 times 24. I'm not going to do the math and embarrass myself on your podcast, but that's a lot of time throughout the day to get vitals taken. And so we've done CET to turn on the skills that are needed to get your temperature taken, to get a blood pressure taken, and the pulse ox read. And for kids, we do that even across the temperature, blood pressure, and the pulse ox. Each one takes less time. So we may start with the blood pressure cuff, The temperature takes less time after that, and then the pulse ox takes less time after that because we've established a contingency of that we're teaching these skills using negative reinforcement. The kid learns what to expect. They have degrees of freedom, so they can assent or withdraw throughout the process. Which is not true if 6 people dogpile on you. You're under a very
Right.
coercive condition in that point.
Okay, so take us into like safe needle or safe anesthesia. What does CET actually look like on the ground?
Yeah. So we did kind of like a pyramidal like teaching approach for one of our largest pediatric primary care units in the hospital. And so this is where like kids are coming just for their like routine care. They do a lot of vaccines, they do a lot of blood draws. And so we taught 15 or so nurses to be what we call like nursing champions for like neurodiversity affirming care program. And so these champions learned to do CET. We did a 1 hour training with them and had them do some like behavioral skills training and things. They learned how to do CET. They went out and then they started doing it. And so then when a patient comes in who may need, who we've identified, like we've tried accommodations and modifications, we're still seeing problem behavior, you're having that nurse step back. We created an assessment tool for when they engage in assessment or accommodations and modifications, and then they proceed with the procedure until they hit a area of distress. At area of distress, they pull back and reassess. And from there, they can either increase accommodations and modifications to care. Maybe they just need to explain the section where they're at in a different way, or they need to move on to CET. And so if they move on to CET in that procedure, they note where they stopped and where that kid engaged in distress. And they're going to take a couple of steps back from there. And so then they're going to use the needle to then build the skill that the kid is missing in that moment. And so maybe what they had the needle, they brought it all the way up to the kid, and the kid like clenched their arms and turned away, showing some distress. And so then the nurse is going to pull back. They're going to hold the needle out, and they may ask the kid to hold their arm out, and they're going to remove the needle. And now they're building participation in care. And they're going to continue to build participation in care until they have a needle, they bring it, and they're able to get a safe blood draw or vaccine. And that's taking anywhere between 5 and 20-ish minutes within a setting. It's because they're specifically targeting the skill that's necessary to participate in their care, which is clearly missing. And again, like it's not about the needle, it's about that negative reinforcement of the aversive in order to build the skill. And once you have the skill, that aversive is no longer necessary to be adversive.
And so, just again, you've just said it, but I'm asking again. In terms of getting a needle or getting a blood draw, what is the skill?
The participation in care. And so some of that's passive and some of that's active. And those are both skills. So even if a kid is just sitting there, they're not hiding underneath the table.
I see.
They're not, ripping down the computers in the room.
Gotcha.
Just sitting there is a passive skill. And then there's active parts of the program where we need the kid to hold their arm out. Maybe they hold the ball. They squeeze the ball, they get the tourniquet. And there we're looking at them not like pulling and things like that. Right. So that's passive. Your left hand is passive while your right hand is active. And so there's specific things that we're looking for them to do. And what makes nurses so good at this is they know they've done so many blood draws, they've done so many vaccines, that they know exactly what a good vaccine or a good blood draw looks like. And they know the skills that the kid needs to do to be actively engaged in those procedures because they've done it a bajillion times. When I go in and I do CET, I've never done a blood draw and you don't want me to.
Right.
And so it takes a little bit longer because I have to ask a lot of questions about what does a successful blood draw look like, or what does a successful EEG look like, or what does a successful MRI look like with sedation. And so our nurses are able to do this so fast because they're so fluent in the procedure that they know exactly what they're looking for active and that passive participation.
And I imagine it's been awesome, but what has been the response of nursing staff, especially, some of these folks seeing this for the first time?
Nurses are so hungry for anything that can work within the constraints and the demands that they are in. They don't like getting punched in the face, and neither do I, but they particularly don't like getting punched in the face, especially with a needle in their hand. And so we've been able to decrease. We've been live in this clinic since January, and they haven't had a single workplace violence event in their clinic since then. And they were having several per month where nurses were getting seriously injured during procedural restraint. Because when you hold someone down, you're putting yourself so close to somebody that you're getting very close to getting hurt, close enough to get hurt, I should say. And so they would see a huge decrease in workplace violence events. They're able to what people would assume in the feedback and the kind of the pushback we got at first was that people are like, we can't implement something that's going to take copious amounts of time to where our patients are delayed, the next case can't start on time. Like we can't implement something that's going to take copious amounts of time. And what they saw was that 5 to 25 minutes at max, and they saw no decrease or increase in their cycle time, which tracks like how quickly a patient comes in and gets out of there. In fact, they actually saw their cycle time decrease a little bit. And still working with kids with some really severe needle phobias who had had previous workplace violence events. Most of the time, when a kid was able to get a safe blood draw or vaccine, sometimes for the first time in their life, parents were crying, telling the nurses that they only signing up to be with that nurse again, the champion nurse, to get their blood draw. We had one kid who just had some accommodations and modifications that he needed to care, and he ran out into the lobby and was like, "Everybody, you need to have accommodations for your blood draw." And he told the whole lobby of kids, which
That's
was really cute
amazing.
and funny. But we've had a great response from families and staff, and nurses feel like they actually have a tool to use. And you think about it constructionally, they're reaching down their toolbox. Now they don't have to reach for restraint. They don't have to reach for these more restrictive procedures or having a parent restrain the child because they actually have a tool to use instead. And that tool is actually much easier to use. And so that restraint has dropped out as a necessary component.
That's just beautiful. What are, just because I also don't get blood draws or needles all that often. What are some of these modifications and accommodations that come in sort of maybe prior to CET?
Yeah, our modifications and accommodations really look like how are we explaining the procedure to the child, and a lot of times, like we can decrease anxiety just if the kid knows what's happening next. And a lot of times, when I went to observe at like our baseline sessions too, like when I went to observe, like a lot of times, like we were just like whipping things out and then just like sticking somebody and not even really telling them what was happening next. We decrease a whole lot of anxiety just by telling someone what to expect and what's going to happen next. And maybe that looks like showing them a visual. Maybe that just looks like verbally communicating that. Or maybe it looks like verbally communicating just in short, kind of like step by step processes. And that's going to be different for every single child depending on their level of support needs. We also gave the units like a sensory cart that has like some little toys and stuff, of course, but like also like they had like what we call like a buzzy bee, which is like a vibrating thing. It makes it supposedly makes it hurt less. I don't know. I think it's a little psychosomatic, but you can put that on, it makes it hurt a little less. They have access to like freezy spray, so if a kid's really afraid of the poke, again, maybe a little psychosomatic. I don't know. Maybe it does make it hurt less. But they can spray this freeze. These are things that they have available in the clinic, but weren't readily accessible. And so these are accommodations they already had. They had sensory toys. They had some sunglasses if a kid didn't want to see it, or headphones if a kid didn't want to hear what was going on or what the adults were talking about. But they weren't using these things because they weren't readily accessible. And so we made these things readily accessible by putting them all in carts. And so they can move the cart from room to room as they go do blood draws or procedures. And again, like these are things that they already had available, but they weren't accessible, so they weren't being used. And so can we make these things more readily accessible? And then if they're more readily accessible, nurses want to use these tools. They just didn't have access to them quickly.
You've also talked about teaching families to run CET. Can you tell me a little bit about that? Maybe run me through a case or two about what that looks like.
Yeah, I think that going back to that OCD case,
Yeah.
those families learn to use CET for UCET for all kinds of stuff. Went in and the girl had eliminated all like the food from their pantries, the toilet paper, like pictures on the walls. And so they were able to use CET to reinstate all of those items back into the house. Again, slowly moving them in and then removing them based on the skill that they were targeting in that time. At the hospital, we have kids. We have a lot of kids who come into the hospital who have never taken medication before in their entire life. They get to the hospital, now they have a medical condition where now they have to take medication. It's sometimes a dire situation. Like when you have a kid who's engaged and has like a really severe epilepsy, you need to take medication so that you don't continue to have epileptic seizures. And so that's when we see a lot of the times families don't have the skill set to target some of these, and our providers don't always know some of these skills to help turn on medication administration. And so people are very quick to hold kids down and shove medication in their mouth because the contingency is if I don't get medication, I'm going to have a really severe epileptic seizure that could be pretty fatal. And so it raises anxiety because the potential consequence is so severe. And so in those cases, we can help reduce restraint for medication administration by using CET to build the skills to take medication. And so that might be look like we hold the syringe of medication out and we just want the kid to look at it. And then we want them to look at it and open their mouth. And then we want to look at it and them open their mouth with it a little bit closer. Again, it's not about the syringe of medication. It's about the contingency and the skill that we're building that skill to get the medication successfully.
And then how do we sort of prevent parents from maybe turning CET into like a gentler compliance?
Yeah, I think that's a good question. And the piece of that is that we're using CET, and CET has an inherent like degree of freedom. So if the kid says no or they engage in distress, we stop and we pull back. And that behavior tells us that we need to change or manipulate what we're doing. And I think the other piece of that is there are some things that we do need to be compliant with, which may be kind of like a hot take in our field sometimes. But when I see a kid who has epileptic seizures to the point where, like, if they don't take their medication, that they will die, that's compliance that I'm okay with. But if there's other things like we're trying to build for like the kid with OCD, for example, she's not going to die if she doesn't have a rug in the house.
Mm-hmm.
And so we're going to increase degrees of freedom there and ask more questions of why or how we can reinstate these things with maybe some accommodations or modifications to how they look or how they're presented. But we're using that behavior as a feedback for us to change what we're doing. So I also like to say when I'm doing like teaching events and stuff in the hospital or I'm teaching staff or teaching parents is like after studying behavior for like the last like 10 years, the only thing that I've learned is the only person's behavior that we can change is our own. And so when we see that behavior, that's a red flag or that check engine light that a WOB likes to say, like that we need to stop, pull back, and then do something differently in our program because it's clearly a program problem, not the kid's problem. And so we're changing our program and we're changing what we're doing to get a different result. But it's also about that we're increasing degrees of freedom so that we're decreasing coercion.
And what are some of the health routines you've seen families successfully address using CET?
Gosh, we've done so many things. We've done EEGs, EKGs, blood draws, vaccines, anesthesia, getting anesthesia mask on, changing out bandages for kids who have burns, engaging in physical therapy or occupational therapy when that has been hard, getting medical exams for kids who have had extreme trauma who come into the hospital. They're clearly afraid of adults for very, very good reasons. And we can use CET to help reintroduce them to the presence of an adult that is not an aversive situation because we're not there to hurt them. We have used CET to get like rectal exams or to give enemas. Not my favorite cases. We've done tons of different things. That's probably just like scratching the surface.
Yeah, absolutely. And what about sort of like, I've heard you talk about a few examples, but like routines that families struggle with in the home.
I've probably done a little bit less of that, but probably the medication administration. We've had lots of families do CET for med administration, and that can go into the home setting. We've had a lot of cases of OCD that I've worked with. We had a family whose daughter was living in a trailer outside their house because she could no longer go inside of her house because of the severity of her OCD symptoms. The house had like some contamination fears associated with it. So the family used CET to get her from the trailer back into the house, and they were able to sell their trailer, which they were very happy about. And so we've done a lot of different applications of CET across a huge variety of different issues. My favorite cases are the OCD cases and the cases where we're able to like quickly turn on. Some of these behaviors are like life-saving for many cases.
It's amazing. You've used the phrase stalking severe problem behavior. Tell me about that.
That was a case I worked with in Columbus for a kid who was engaging in some stalking behaviors. This is not a CET case or a case that we use CET with. This is just a straightforward constructional program. This kid was engaging in stalking of one of his neighbors, and he had police involvement because that's not something that's socially acceptable generally. And he was like peeking through her windows and like at all hours of the night, and was engaging in really severe aggression towards his parents in order to get to the lady's house. When they would block his access, he would engage in severe problem behavior and aggression and property destruction in the home. And so he had been kicked out of his talk therapy sessions because he was engaging in some pretty severe aggression towards therapists and towards his family when they moved over to telehealth to get out of the session. And so we brought him into our complex behavior program. And there, we worked with him to complete the constructional interview with him, and we also did a constructional interview with the parents. And when we did the constructional interview with him, one of the questions on the interview is, "What do you hope happens when you engage in X, Y, and Z, whatever the problem is for him? Like, what do you hope happens when you go and you stand on this lady's porch?" And he said, "Oh, well, I hope my friends come and invite me to play with them again." And I was like, "Oh, that's not the answer I thought I was going to hear." You think you think you're going to hear like, "Oh, I want to look at her. I'm attracted to her. I like this lady. Like, I want her attention." It was not about the lady at all. His friends had come. We started asking more questions. He had been invited in the neighborhood for the very first time by this group of guys. And they were going around and they asked him to go up to the lady's house and to ring the doorbell to ding
Mm,
dong ditch her. But he didn't get the ditch part, and so when he rang
course.
the doorbell, the lady came out. His friends booked it, friends, in quotation marks. They ran away because they weren't really his friends. They were bullying him essentially.
Yeah.
But they were the first people who had ever asked him to play
Mm-hmm.
willingly, and so he was like, "Yeah, this is amazing. I'm making friends. Like, I really want peer attention, but it's been hard to get because I'm not set. I have the social skills to engage in peers." And so he rang the doorbell. This lady came out, started screaming and yelling at him, and his friends left. And so for him, he started making up stories like, "Oh, well, maybe they had something to do, or their moms called them and they
Mm-hmm.
had to go home." And so for him, he's like, "If I go back to this lady's house, maybe they'll come back and get me." Well,
Oh
they never came back to get him, and he kept going to the lady's house.
my
And then
gosh.
what people kept asking him was like, "Well, why are you going over there? Are you peeking into her blinds? What the heck are you doing?" Their verbal behavior about his behavior created stalking behavior. He wasn't actually stalking her to begin with, but people started asking him because that's what the behavior looked like topographically, functionally, not what's going on. No one asked
Mm-hmm.
functional questions. They just asked questions about what the behavior looked like. And by asking more questions, he said, "Well, maybe if I do look through their blinds, my friends will come back." So then he started actually engaging in stalking
Oh my
behaviors.
gosh.
He had never had any intention of stalking this lady, but his behaviors quickly were shaped into stalking behavior. And so we ended up teaching him how. We asked him where those kids were, even if they weren't good influences. We knew he wanted their attention. And all those kids had played baseball in the neighborhood, so we taught him how to play baseball, which ended up helping him and his dad repair their relationship because his dad had always wanted him to play sports. So we taught him to play baseball. Him and his dad started going to the batting cage. He was able to join the baseball team. We taught him to use social media to access other peers that he liked. He loved severe weather and things. Not my jam, but we found him friends online who also loved tornadoes and stuff. And so he was able to interact with people there. And we also taught him how to he really wanted a girlfriend. So we taught him how to how do you keep someone's attention? Because he would also at school, he would look up all kinds of things about girls and learn all like your grandpa's brother's sister's name, and which scared people, but scaring people kept them talking to him and gave him the longest
Mm-hmm.
conversations with peers he had ever had.
Mm-hmm.
And so we taught him how to talk to people and increase the duration of his conversations with them without having to scare them into staying in the conversation.
Yes.
And so we taught him all these social skills. When we taught him social skills, he stopped going to the lady's house. Now playing video games with his mom became more repetitive because now he has some of the skills to engage with her again. He doesn't need to go to the lady's house because he's able to access those peers at baseball. He did decide that he didn't like those friends, which I think was a great, which was a great outcome to the story because those kids were kind of jerks. But he found a friend at baseball that he ended up liking. He quit baseball and then they became friends at school. All severe problem behavior dropped out at school because he now had a peer. Behavior dropped out at home because he didn't need to go to this lady's house anymore. They weren't blocking him from leaving the house. They were able to play games, and his dad got what he wanted. Like he got to play sports with his son for the first time. So by building these skills, all these other pathological stalking behaviors dropped out because they were no longer necessary, and they weren't necessary to begin with. It was the only way he had to get those peers to come back.
In such a short time, you've really built a neat program at Vanderbilt. What are some of the up and coming plans and sort of future goals for that program?
Yeah, we're expanding some of our safe needle-based procedure program is called Creating Access to Life-Saving Medicine, and so we have that program that's going to be expanding across different areas. We have a safe anesthesia program that's coming up with some of our sedated dentistry kids. 'Cause if you need sedated dentistry, there's a reason why you can't get regular dentist work
Hmm.
at a typical dentist office. And so we're working with them to increase access to safe anesthesia and expanding into some of our other outpatient clinics as well. And then hopefully expanding some sites along the way, not just at Vanderbilt, but other hospitals. And then we'll be building a severe complex behavior program here at Vanderbilt, which I'm really excited about. We have a lot of kids who come and have this repeated hospitalization cycle when they come to the hospital and then they go inpatient. Inpatient services are actually easier to access than outpatient services because outpatient services for a kid with that level of acuity just really don't exist. And so we'll be creating that access point in our community, which is really exciting. So well, there's a couple of things down the line. We have a couple new behavior analysts that we're bringing on to be able to expand our service line at the hospital, which we're really excited about, and expanding some of like our constructional exposure treatment into like our feeding and acute ARFID cases that we see in the hospital, and moving into some different areas of the hospital that we're not currently able to get into because I'm only one person. So once we have a couple more people, we can expand our access to our service line a little bit, which is exciting.
Have you done or seen any work with this being done in kind of like pre-hospital care? You know, I'm thinking about sort of first responder, ambulance, paramedics, and firefighters. I work as a first responder, or I volunteer as a volunteer firefighter, first responder. Been doing it for a while, and I wonder about some of these sort of emergency medicine type techniques where we like we need to get that bandage on you now, or we need to obviously when we're getting into sort of more extreme life-saving measures, we're not so much worried about consent because typically the
Hmm.
patients aren't awake anymore. But some of these sort of because it's obviously it's a very dramatic situation, a lot of sensory overload, a lot of things going on. Have there been any work in that area that you know of?
Oh, we're starting a project with our paramedics
Hmm.
and our emergency transport teams, introducing some of the calm pieces, but also doing kind of like constructional nonlinear analysis for them of like what are some common issues that they see in transport behaviorally, like from their
Hmm.
patients.
Hmm.
I rode around a few weeks ago in an ambulance for quite a while
Hmm.
to see kind of like what some of the constraints of that environment were.
Cool.
So we have some projects that will be rolling out there.
The third secret word is bridge.
I think most areas in like kind of like the police work and fire department things, those are have been mostly like accommodations and modifications area of like, can we give these responders easily accessible items to help them decrease agitation and things like that. And so hopefully like expanding some of that tier two.
Yeah, yeah, really awesome. For clinicians listening who are thinking, I want to learn this, I want to get into this. What's the pathway for them?
That's a good question. Well, I guess a few things. Like I always recommend people read the nonlinear contingency analysis book. I feel like that's a good like entry point. And some of the articles that have been published within the last couple of years in the constructional approach. Timothy Leiden had a great article about working with parents. Dr. Lang and now Dr. Abdel Jalil as of yesterday.
Wow, amazing.
Yeah, they have a paper on the seminal paper on CET. That's a good read. Uh, there's quite a few the preemptive compassion paper by Dr. Linehan. There's several like good entry points later this year. This summer, the new version of the nonlinear contingency analysis book will be published. That'll also be published, the case studies book, which will be a great kind of pairing to see the background and the conceptual side of nonlinear contingency analysis and the constructional approach, but then also how that's applied. So I'm really excited for both of those to come out together to get a really like full picture of what we're doing there.
And so from there, from sort of reading a textbook, reading some articles, is it a matter of sort of just trying some of this stuff out and looking for feedback, or are there kind of prerequisite skills required, and maybe in sort of that thought process?
Yeah, I mean, I think the golden question is like, what are the prerequisite skills to be able to implement some of this stuff? When I'm teaching like nurses and things like
Yeah.
that, nurses are great constructional behavior analysts because they don't have a prior learning history of behavior analysis. This is like their first entry,
Right.
and I find that a lot easier. And people who have a longer history of behavior analysis maybe are a little bit harder. Parents are great behavior analysts, constructional behavior analysts, again, because they don't have that previous learning history. In practice, when I've seen families who've had ABA for a lot in the like in the early intervention, now the kid's like an adolescent having really severe problems, those parents are a lot harder to become constructional. And I think that's the same for behavior analysts too. The golden question is, what prerequisites do you need? I don't know. But I think, like, just, like, curiosity to, like, learn more, and again, like what you said, like, "Let's try this, and then let's see what happens," and then, seeking feedback. We have a Facebook group online for the
Mm.
constructional approach, which is a great place to ask questions. We love when people ask questions in there, to give feedback or give additional resources or things like that, and then just creating, like, a community. When I got first started getting into the constructional approach after I read the book for the first time, I went to ABAI that year and then just, like, stalked I was a stalker in this case. Stalked Joe and Dr. Linehan and Dr. Michelle Jail, and just kind of like followed them around to anything that they were interested in. I was like, I'm probably interested in that too. And so just like creating a community of people who are interested in the same thing.
Yeah. I mean, it really sounds like the prerequisite skill is to not have any experience whatsoever. You'll probably do a lot better than the folks that do have the prerequisites.
It's just a different way of thinking, and it's hard to move from the pathological view of behavior. I still get caught up in the pathological view of behavior. Sometimes I'll walk into a patient's room and see like, oh, this kid is psychotic, or this kid has OCD, or this kid has, whatever the pathological thing is. And it's hard to shift from a pathological approach to a constructional approach. And so I'm like constantly like checking myself to say like, oh, nope, we're not thinking about pathology. Get rid of that idea. What skill needs to be present in the absence of which is the problem? So I think like continuously also like checking that like previous learning history, which is like can be like so salient.
Zooming out a bit, where do you see CET and constructional work going in the next decade?
I'm really I think we have a lot of traction right now for the constructional approach. People are very interested. People are like really hungry to like learn more. I'm really excited to see it expand across our field. I think the constructional approach is not new. But I always like to think of, like, what would have happened if, like, our field would have grabbed onto the constructional approach in 1974 instead of, like, going down, like, the Lovaas path or the 4 functions of behavior path. And all these things are, like, tied together, in art history, but I always wonder, like, what would have happened if, we went with Gold Diamond, and held on to those ideas. Like, I think maybe the state of our field will a little different, but I'm hopeful that I think the construction approach and nonlinear analysis adds a lot of value into our field, and is, very naturally ascent-based and has a lot of things that the field is really hungry at looking for right now currently. I'm really hopeful that people grab onto that and we see a huge like expansion and more availability of like trainings and things like that for people to get more involved.
What's something about the constructional approach that people struggle to understand, but should?
I think that's a good question. I think the biggest piece is that, and what we talk about a lot too, and we get questions at conferences, is that like the construction approach and nonlinear analysis can be applied to all different people, from animals to kids who are extremely verbal and maybe have like psychiatric comorbidities, or anyone who just has like a problem that they want to solve, to kids who have nonverbal high support needs, autism, like across the way. And I think the other piece is that we're not looking at the linear contingency, that ABC analysis, and taking that and throwing it out the window. It's expanding that view to see a more ecological view of behavior, not a very like singular, minute, linear version. Nonlinear doesn't mean that we're throwing things away. We're expanding that analysis to add in additional factors that we're considering in our program. That analysis leads to a better program. And we may accidentally get to a good program where we're establishing behaviors. But we also get a lot of people who say, like, I'm already doing this like instructional work. And you can be constructional without being nonlinear, but you can't be nonlinear without being constructional.
Hmm.
And so the piece that I think is that we get that for people who say like, "Oh, I think I'm already doing a lot of this," you probably are, and you're probably being very constructional. But that analysis is going to help you dive into the exact behavior that needs to be established in which the absence is the problem. And so for I think skills-based treatment is a good example of this. You can build a great SBT program that may ultimately decrease the problem behavior over time because you've built up the skills, but you may be getting to those skills on accident because in that analysis, you're looking at like, what could this kid be doing? What does the family want the kid to be doing? What does the educator want this kid to be doing? And you may build the right skill on accident. But what you do when you add the nonlinear analysis is you're taking that ecological view to see
Yes.
exactly what you have, that precision to see what
I
behavior
love that.
actually needs to be established in which the absence is the problem. You can build that up very quickly. And you don't have a lot of other like noise of other behaviors that you're building up or decreasing or things like that. And again, we're not decreasing behavior, we're just building skills, but we're targeting precisely what skill needs to happen. We're not getting there by accident, if that makes
Yeah.
sense.
No, it totally makes sense. And if you could go back to yourself, that early career clinician feeling stuck with three or four kids with FAS, what would you tell them now?
The kids with FAS,
What would you tell yourself, the early clinician who's stuck in that situation?
probably that there's more to this than there's more. There's a better way to get to solve this problem. There's like a hope to that because I think in that those early stages of my career, I feel pretty hopeless of like, is ABA even worth it? Like, is this like why am I doing this? 'Cause I'm not getting any kind of like the result that I want to see, and like, are we causing more harm than good? But I think like when we're able to really precisely like zone in and we're not focused on decreasing problem behavior at all, that's never our goal. There's like a hope to that. I think that gives us an area to be like more precise in our teaching. And then also kids who are participating in these like constructional programs want to be engaged in the constructional programs. Like that kid with who was stalking, he hadn't participated in therapy for years and he was engaging in severe problem behavior, and he wanted to come to our program. He would beg his dad to bring him multiple times a week, even though we could only see him once a week, because he knew that when he came to our program, we were building skills that actually mattered to
Yeah.
him, and that he wanted to be building. And then he would get to go and try the skills out that he had just learned in the session. So he was like contacting reinforcement, and we're not using arbitrary reinforcers. Like we're using reinforcers that are already within the contingency, and so we're getting people what they're after in a better way. And so I think those pieces like bring a lot of hope. And I wish I was that hopeful as an early clinician, but I'm glad that I got there.
That's awesome. That's
So I
awesome.
probably would have quit the field.
Amazing, amazing. Well, I hope it brings some hope to some of these young folks who are struggling. Katie, this is really cool. Thanks for coming on and telling me all about all the great work you're doing. I'm excited to see what happens next.
Yeah, no problem. Thank you for putting all this content out there. I think it's really helpful for people to see.
Thank you. Thanks so much for listening to this episode of Behavior Speak. If this conversation challenges the way you think about behavior, be sure to subscribe so you don't miss future episodes in our Constructional Approach series. If you enjoyed today's discussion, go to behaviorspeak.com, click on categories, and click on Constructional Behavior Analysis to check out the other episodes in this series. Katie's examples today, from reducing restraint in hospitals to helping individuals build lives worth participating in, highlight how powerful behavior analysis can be when our focus shifts from suppressing behavior to constructing meaningful alternatives. If you found value in today's conversation, please consider leaving a rating and review wherever you listen to podcasts. It helps more people discover Behavior Speak and supports our mission of sharing thoughtful conversations that move our field forward. Until next time, thanks for listening.